Good evening, everybody. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network and I sit in the New England. Welcome to our CKD webinar series tonight that we are doing with Kidney Health Australia, and this is our first session. Before I go any further, I'd like to acknowledge the traditional custodians of the land that we meet on tonight and pay respect to elders past, present and emerging. We are very lucky tonight to have a GP facilitator. We have Michelle Guppy, who's a GP in Armidale, and she will be facilitating the questions. And we have nephrologist Dr. Stephen May from Tamworth. So I will hand over to you, Michelle.
Thanks, Jenny. Welcome, everybody. It's great to have you all here. And as Jenny said, this is the first in a series of 3 education evenings about kidney disease. And it's great that we've got some local nephrologists who are going to be presenting. So I don't think Dr. Steve May needs any introduction to New England GPs, but for those of you who are from the Hunter region, Dr. Steve May is a VMO nephrologist who works out of Tamworth, but has been delivering care around the entire New England region. And tonight he's going to be talking about decision-making and symptom control in kidney failure. And as we said, this is the first in a series. In a couple of weeks, we'll also have some cases around hypertension and chronic kidney disease and diabetes. And then finally, early detection and management. So great that we can have this series being presented locally. So welcome, Steve, and I'll hand it over to you.
Thanks, Michelle and Jenny, and thanks to everyone who's online. Obviously, starting to get used to doing online presentations, hopefully not for too much longer. So, first thing is trying to get the slide to go down. Was working before, now it's not working. Jenny, can you make that happen? Remember, we might have to just go back into it. Jenny, that happened earlier today, so we might.
Yes, I certainly will.
Sorry about that. I'm not surprised. I am the most technologically illiterate person in the planet, and
That's all right. Look, in the interim, everybody, we've disabled the chat, but there is a question section, and if you want to ask a question, please just type your question in, and partway through, if it's relevant to what Dr. May is talking about, he'll answer the questions through the talk, or we will do them at the end. So just have a look at your question function and pop your questions in there.
So we're away. I'd like to just acknowledge the traditional custodians of the land as well, and in our country it's the Gamilaroi people, and if people are up our way, they should go to the Myall Creek Massacre site at some stage. It actually gives you an interesting and a very sobering perspective on our background history and obviously an element of our culture now, which is clearly started with the Aboriginal culture. So in terms of housekeeping, yes, times of COVID, obviously I don't have to tell you where the toilets are or any other of those things, so that's good. There are some advantages of COVID, but yeah, happy to take questions along the way, and Michelle will interrupt to ask those if people like, or at the end. So I'd just like to acknowledge the various people and sponsors in Kidney Health Australia for this. I do I am actually giving a talk. Normally I do my own talks and I always find it hard giving other people slides, but these slides are very good. So I haven't really made a lot of changes and additions, but just some. So the learning aims are to describe the comprehensive conservative care. This goes by many names. I used to think of it as a non-dialysis pathway. So I'm thinking when I see end-stage kidney disease, I'm thinking dialysis or non-dialysis. But in fact, thinking of it as a not as a negative as in a non-dialysis pathway, but a positive pathway, I think is a very good way of looking at it. Recognise and manage some of the symptoms and discuss the end-of-life care settings in kidney failure. Just a little bit of interesting historical background. A number of years ago, Mark Brown, who was a nephrologist at St George, and I worked on a plan to actually have a conservative care pathway. And within the ANZSN, the Australian New Zealand Society of Nephrology, I was chairing a sort of fairly significant committee at the time. And there was a lot of debate as to whether or not we should have a conservative pathway. A lot of people were, and very, colleagues that I respect a lot, were very antagonistic to have this pathway at all, because they thought people would be then encouraged not to do dialysis for reasons not involved in their care, and in fact saving money, etc. So it's actually it's hard to imagine that it's a relatively new concept, because I'm sure GPs have been doing this forever, but in the society it was a bit controversial at the time. We had some pretty heated meetings of heads of units. So this slide's here, and I had to leave it there because I love my job, love my job, love my job. And in fact, one of the things I enjoy most about nephrology and managing people with chronic care is actually helping them die. And chronic kidney disease has a high mortality, and you get involved with the patients. I find it as rewarding in many ways, and more rewarding in some than looking after them during life. But it's such an important thing. Frank Brennan says a good death is one that's remembered forever by the families, and a bad death also. So it's a really important aspect of care, as I'm sure any of the GPs would agree with. So chronic kidney disease mainly we define it by EGFR. There's lots of things that kidneys do. They make hormones, they control acidosis, do lots of things. But when we talk about kidney failure, we don't think about those things. We just think about GFR. But it's also defined if there's kidney structural damage. So if someone's got a single kidney, we'd call it chronic kidney disease, even though they might be very healthy after a transplant nephrectomy, say, or if they've got hematuria or albuminuria, even with normal GFR. So there's different ways of thinking it. But I think most of us practically are not too worried if someone's got 30 milligrams of microalbuminuria and they've got normal kidney function and normal blood pressure. They're not actually being impaired by that. So just to wake you up a little bit, but how prevalent is chronic kidney disease in Australian adults? And that includes all of those categories. So single kidney, scarred kidney. So it's actually not uncommon. So there's plenty of work for nephrologists, and it's 1 in 10. So if you just look at the numbers, 1 in 10 people will have some sort of kidney problem. Often they're not aware of that. And one of the kidneys are sneaky. You can lose 90% of your kidney function without really many symptoms. A little bit of nocturia, because you can't concentrate the urine, is probably the earliest clue. But then, often no real symptoms until the EGF or the GFR is less than 20. So it's really something that's just got to be screened for and thought about. And one of the things about kidney disease is it's a major independent risk factor for cardiovascular disease. I used to teach, and it's not quite true anymore, that if you've got chronic kidney disease, don't worry too much, because you're likely to die from your heart, not the kidneys. That's changed with all our statins and some of the cardiac interventions. So in fact, a lot of people are now dying from kidney failure and end-stage disease. So this is a sobering slide, and I think it is actually worth keeping in mind when people are asking about dialysis. And we're a bit, in some ways, we're a bit dishonest with people. We sort of put up, you can have kidney replacement therapy, or you can die on a conservative pathway. But you've got to, particularly as people get older, the risk of dying on dialysis is up there with lung cancer and other significant cancers. So the 5-year survival is around about 50%. And this is across all age groups. Well, this is age 60 on this one, but so it's better in some age groups. So polycystic kidney disease do a lot better. People with diabetes do worse. But renal replacement therapy with dialysis does come with a lot of comorbidity and vascular disease. I'm sure most of you are aware that your kidney function declines with age, so we've got to think about which age is specific. So someone at 80 with an eGFR or a GFR of 50 is about right. So I think it says here 5 to 8 mils per decade. I can't do that in my head, but I think 1 mil of loss a year around about 30 to 40. So it's around 10 mils of loss of GFR. So someone's 80, they have lost about 50% of their GFR if you take off 80 from 30. So 50 would be, a GFR around about 50 would be about right. I think it's easy to do that. In terms of age and kidney failure and what we know, we do keep a very good registry of people on dialysis and transplants, but we don't have any registry really of the people that don't go down a dialysis pathway or the conservative pathway. But we know that as people get older, there's a lot more people on the conservative pathway than the dialysis pathway, and that's very appropriate. So nephrologists are looking after a small fraction of this compared to the GPs. So who cares for kidney failure patients? Well, often, as I was just saying, as people get older and frailer, it's going to be the general practitioner, and certainly I look after patients as well because I've known them for many years, but it will often be the GP. And a small percentage get referred to a nephrologist, and that can be appropriate. Although I must say, when I first came to Tamworth, and there were people around here that were not being referred because there was no real good established service. And I would see 60-year-old people who were not offered dialysis, and that can be inappropriate as well. So, case study. You all know this man, even if you don't recognise his face. He's a 74-year-old, he could be an 84-year-old now. I saw a 94-year-old farmer recently, same history, lives at home in a small town, fairly established relationship with his wife. And he's got the usual suspects that you see in this age group. So he's got a bit of type 2 diabetes, and it's been complicated by neuropathy and retinopathy and some foot ulcers. So immediately he's not looking so good. He's got hypertension and he's got cholesterol problems, and he's had some heart disease, and he's had a left nephrectomy for a cancer. And his eGFR is 18, so 70 or so, you'd expect his eGFR to was about 40%, so 60, he's got half a kidney, he's lost a kidney, so 30 should have eGFR 30 to 40, yet it's 18, so it's clearly some other underlying disease. He's got proteinuria, needs oxygen at night. He's not looking so flash, and he's on a few medications, the usual sort of stuff. So people use this staging. I'm a bit of a heretic. I don't often use it. To me, because if you've got a stage 3 kidney disease, your GFR can be anywhere from 30 to 60. If my eGFR, my GFR is 59, I'm sort of feeling a bit happier than if it's 30, and yet it'd be all stage 3 kidney disease. So yes, I think it's useful. But I must say, when I'm doing my letters, I don't talk about stage 2 or stage 3. I talk about the GFR. I think it just makes a lot more sense to me to know what the GFR is, which sometimes it's often the same as the eGFR, but it's not always. But anyway, this is a risk calculator, and it's quite useful because it gives you some criteria to know risk. So obviously you take the GFR, which is the eGFR we get. You make sure it's the same as the GFR. If someone's missing a leg, it might be miscalculating, or if they've got liver disease, it'll underestimate it. And you look at the amount of protein, and we all know that there's more protein, there's more risk. And if you're in the red zone, it's not so good. So it does give you a feel for this man. He's in a lot of trouble. and he's heading into more trouble. So the managing CKD booklets that's out there and the various web pages, etc., are quite handy for this, because you can look at different action plans. And I won't go through all of these, but if they're in the yellow, the goal is obviously to understand what the cause is and reduce progression. Do calculating the cardiovascular risk, which you know it's probably going to be high, and avoid nephrotoxic drugs. And then as you move from one phase to another, you add in more complexity, looking at various things like anemia and bone management. And ultimately, in the red phase, you're looking at which pathway you're going to go down. And I think that's really important. Whenever I see a patient with chronic kidney disease now, I'm thinking about, you know, and I tell them, like, you're going to reach a stage one time where you're going to come to a fork in the road, and you've got to go left, which is going to be a dialysis, transplant, renal replacement pathway, or right, which is a conservative pathway. And you don't need to make that decision now, but that's what's going to happen, and we need to be planning for that. So I guess coming back to a multiple choice question, just going to let you have a little bit to think about what you do with this man. So what are the goals? To continue to monitor Jim, well, that could be a goal. I don't think that's inappropriate. Refer to a nephrologist, possibly. You're the GP, you're looking at this man, he's looking not the best, and maybe he's just going to waste $200 coming to see me. And I'm going to tell you exactly what you already know. But sometimes, obviously, the family want that. I think it's reassuring. If you think someone's reasonable to be on a conservative pathway and someone else thinks that, that's going to be very reassuring for the GP, for the family, for the patient. Obviously discussing treatment options and discussing advanced care directives. So they're all potential goals, potential things. And in fact, I think B, C and D came up as the correct answers, but I think they're all pretty reasonable answers. So who should we refer to a nephrologist? Well, I think there is an argument if someone's got progressive loss of kidney function, at least let someone run the ruler over them, make sure there's nothing could be done to slow it down. Because if someone's losing 5 mils a year of GFR and you can slow it to 2 mils a year, that gives them a lot longer life to live over a number of years. Obviously, discussing options. Not everyone's familiar with all the options, and I think getting a nephrological review about that is realistic. And discussing advanced care directives. It's interesting, we had a meeting on this with the John Hunter people on Tuesday, a regular session we have, and one of the doctors there presented a paper on this. And you know, a lot of nephrologists they don't regard discussing advanced care directives as part of their job, and yet it probably should be, along with all of us who manage chronic patients. So in terms of guidelines, who to refer, I know these are pretty loose. You know, GFR's 30 coming down, but it might be better to refer when they're 60 and losing kidney function. So I think if people are losing GFR and you're estimating how much they're losing a year, and that's more than the 1%, you've got to ask yourself, well, could nephrology help? Albuminuria clearly makes it more likely we might be able to find something we can do, some of the preventative strategies. And hypertension that's uncontrolled, they're the things that obviously we have some expertise in. Where it's not necessary, I get referred people that are 80-year-old with a little bit of microalbuminuria, an ACR of 20 and an EGFR of 50. And really, I always feel bad, I feel like that sometimes I can't actually charge them my fee. I'll just do a Medicare because I just feel that they shouldn't really be seeing me, so I can't really charge for that. So I think if someone's not got a lot of proteinuria, sort of age appropriate EGFR, and it's not changing more than a mil or two a year, we're probably not going to do much. But there's no hard and fast rules. So I just put this in. This wasn't part of the slide, but recently, preserving kidney function is obviously really important. This is a study that's just come out called the DAPA, the flows and CKD study. And in this study, they took people that had diabetes and they took people who didn't have diabetes, and they gave them an SGLT2 inhibitor, in this case dapagliflozin. And they looked at various outcomes, heart and kidney, and that's kidney failure and progressive kidney failure in this group. And even the patients that didn't have kidney disease, didn't have diabetes, actually did very well on dapagliflozin. So if you've got proteinuria and kidney impairment, and you put people on dapagliflozin, that's like putting them on a RAS blocker. They do very well. And if you look here at the second sort of paragraph there with kidney-specific outcomes, they were managing people in stage 4 disease. So this is not helping with diabetes, because dapagliflozin probably doesn't help when the GFR is less than 40 or so. But this is helping stop renal loss due to other mechanisms rather than sugar. It's like hemodynamics in the glomerulus. So again, there are preventative strategies. I think we'll be seeing a lot more of these drugs used for kidney prevention. And this is a really important concept, I think. So if you can slow the GFR down, and this is what this is a canagliflozin study, I know these are in diabetics, but so it's not uncommon for an untreated person with diabetes and diabetic nephropathy to lose 10 mils of GFR a year. That's what I used to teach people. I'd see them, they'd have proteinuria and renal impairment and diabetes, and I'd say in 5 years you'll be either dead or on dialysis, so go and enjoy life and have your holiday, because that's what's happening. And now we can slow that right down. So in the canagliflozin study, the people that weren't on canagliflozin are losing about 5 mils a year. And with canagliflozin, they lose 1.8 mils a year. And that gives them 15 years off dialysis, which is a huge benefit over time. So you don't have to change it much to make a big difference to someone's life. That can be the difference between seeing your grandchildren grow up or your children. So treatment options, obviously prevention is the best way to go. And a lot of that's done by general practice, and clearly nephrologists can't do all of that. That's general practice stuff. So RAS blockers, salt restriction, blood pressure control, all of that stuff's really important. If they fall off the cliff and we're waiting at the bottom, there's dialysis, and I make my living by doing dialysis, and I think it's a wonderful treatment. But it's got its limitations. People don't appreciate this, but on dialysis, you're giving about a GFR of 10. Really good dialysis, if you do it daily, overnight dialysis where you're doing 6 or 8 hours overnight, you can get it up to about 30, sort of getting there the same as a transplant. But the standard hemodialysis, peritoneal dialysis gives the GFR of around about 10 to 15. If they've got a bit of urine output, yeah, that might be 20, but it's not like 50% or 100% of kidney function. So transplantation, obviously you get a kidney, so you get 50% GFR, so that's pretty good. And it doubles your life expectancy compared to being on dialysis, but it's still, there's still issues with it, obviously, with the drugs. And then there's comprehensive conservative care or conservative care pathway. And it's a legitimate pathway, and I think we shouldn't think of it as if you don't choose to do dialysis, you can go on this other pathway that's not as good. Because often the comprehensive care pathways is what's appropriate for people. And it's an active pathway, so we're looking at symptom control and those sort of things. And progression to end of life will occur. Well, that's going to happen on dialysis as well. So that's not different. It's just where the end point is. And it's about lifestyle and quality of life over sometimes the longevity of life. So if you look at someone who's 80 on dialysis versus not, overall they get 6 months, a year, maybe extra. And that can be, half of that can be in hospital just with all the procedures and stuff. So it may not give them much quality, it might be worse for them. So in terms of CKD pathways, just running through this, obviously in primary care, you're going to screen people, you're going to make the diagnosis, risk factor reduction, etc. Maybe referral to a nephrologist. and estimating, the risk of progression, trying to educate people about what's going to happen and the options. And then if it progresses, there's dialysis or renal replacement pathway or a conservative pathway, or a renal replacement pathway, which becomes a conservative pathway later when they withdraw. And then there's palliative care and end of life. So it's the whole group there. So decision making, it's not a static thing, and people, are not going to make up their mind the first time you see them. It does require giving the options and having a reasonable understanding of options. I can talk anyone into doing dialysis, or probably anyone into not doing it, by the way you present it. But I think you've got to try and be as objective as you can. So case study. So if I was looking after this man, I see this man on paper and I'm not thinking dialysis pathway. He's frail, he's got a lot of comorbidity, he's getting on in years, and dialysis is probably not going to do much for him. And he doesn't live where there's dialysis, so he's going to have to move. This is not something that's necessarily people appreciate in the city, but this guy to actually get dialysis, he'd have to do home dialysis, which he's probably going to struggle. So he's probably going to have to move. If this was you and you were this man, what factors might you think about which would change your management? And I think we're all pretty aware of that. I think if we walk in someone else's shoes, we can make good decisions often. So what's important for patients? Well, often lifestyle and quality of life. In patient surveys, patients don't necessarily want extra time, they want quality of life. Whereas when we're doing all of our sort of assessments, it's about length of time of life. We have to do a yearly survey on all the dialysis patients, and the report I get back is, what's the sort of death rate and how long they live on dialysis and those sort of things. There's really nothing about quality of life on dialysis we survey, and that's changing, but this is what patients are interested in. So, the time of dialysis is available. So some people have to dialyse in the afternoon, they're going home in the evening because of just the logistics. The number of visits per week. So most people, that's going to be 3 days a week. They've got to come to the dialysis unit. When I first came to Tamworth, we had patients in Moree coming to dialyse in Tamworth. A 3-hour trip down, 3.5-hour trip. I've done it many times. 3.5-hour trip back, plus your 5 hours on dialysis. So you'd be just exhausted, and then you recover the next day, and then you do it again. So that's a terrible lifestyle, I think. The costs of transport. So it used to be ambulance that provide that. The ambulance have bailed out of that now, so it's become very difficult. Travel options, holiday options, difficult but possible, particularly with PD. And one thing I added here is relocation. In the rural areas, people have to relocate often to be near a dialysis centre. And then you look at this frail old man. He's going to sell his house. His wife's going to move here. He's going to die in 12 months. Or 6 or whatever, and then his wife's going to be left here by herself. Is that a good thing? Maybe, maybe not, but we have to address that. And so life expectancy, reduced burden, restrictions imposed by dialysis is the equation. So it's really a balancing act trying to work that out for each patient. But I think we've got to be realistic as well about this time that you think they have. And the surprise question is a good way of putting it. I put it to that. I say to them, looking into all your problems, would I be surprised if you're on dialysis? Would you, if you died in 12 months, would I be surprised? This man, I'd probably say, well, I probably wouldn't be that surprised. You'd be lucky, all your other problems. If you live 1 to 2 years on dialysis, you'd be doing well. Is that worth selling your house, doing all that? So, coming back to Jim, we discussed the treatment options with him and his wife. Jim's got a pretty good understanding. If he's having struggling with the decisions about his treatment, what would you do? Obviously, you could think about that in the chat box. And I must say, these webinars are difficult because of this. I've got no idea what people are thinking. But you know, I think everyone will struggle with this. This is a difficult thing. There's very few people that come along and just say, I want to do it, I don't want to do it. I had a friend that did it and he was terrible, I'm not going to do it. So it does take a while to work through these decisions, and people will be guided by the expertise. As I said, I can talk people in or out of it. If I was short of an income, I could obviously put more people on dialysis if that was my motivation. So I think this is the way I look at it when I talk to people. This is one of my slides I added in, but you know, you've got three options when I see you with these, when I'm discussing it, and it's the same if you're discussing it with you as a GP. You've got renal replacement therapy option, you've got a conservative care pathway, or you've got an undecided pathway. So people will often be undecided, and people sometimes are undecided right up till the time where they're getting uremic and have made a decision. And I think that's a legitimate pathway. Not everyone can make their, you know, it's not the ability to make that decision. It's pretty important, life, death, family pressures, all of that. So sometimes in that situation, I will put people on dialysis saying you're undecided. You could give it a go and see how you like it. The one advantage of being on dialysis that you have over everyone else who's not on dialysis is anytime you like, you can stop and you'll have a really nice death. You'll go to sleep and you won't wake up. So I think putting it in those terms is actually very useful. So legal issues. So I'm intrigued by this from KHA and this standing. So where do things stand legally when a patient refuses dialysis treatment or chooses to stop dialysis treatment? So when I first came and I started to do the ANZ data form, there was no, so we had to actually put why people died, and there was no choice that patients declined to have dialysis. The only choice was patients refused dialysis. Like they were actually doing something against what was the norm, and so I don't use that word refuse anymore, and it sort of it's a red flag to me. So I think it's a very legitimate option to decline dialysis. You've got the option, you can have dialysis, you can not, you can decline it, you can choose it. And refuses has a very negative connotation, as though they're doing something against what should be done. So Jim makes an appointment to see you without his wife, and it's very clear he doesn't want to be hooked up to a machine, and he wants to be at home. He wants to, you know, stay at home. He doesn't want to have to travel and all of that. But his family are unhappy, and often you get that. Family all want him to do it, but they don't have to do it. And they're going to drive him. They'll bring him down every week until 2 weeks later, and suddenly they realise that they can't do that because they've got to work. So I think it's actually really important to have the family on side and have those sort of conversations together. And it takes time. You can't do this in a 5-minute meeting, and you certainly can't do it with a teleconference. So it's not good for everything. So legal issues, unless incompetent, patients have an absolute legal and moral right to consent to, withdraw, or refuse, again, decline treatment without any obligation to explain it. And I think most of us now would be pretty comfortable with that. I think doctors, as our profession and as nurses and health professionals, we have the responsibility to inform fully, discuss options and reasons, and offer support. And I think we have to give an opinion. That's not put there, but you know, people want an opinion. You know, when I go to see a dentist and I go and sit in the chair, I don't want him to give me all the options and then not give me an opinion as to what he thinks he should do, because I've got no idea. So people need to have an opinion and it's expressed as this is what I would do if you were my mother or whatever. So I think that's a really important responsibility. I'm still a bit paternalistic, I guess, in terms of the way I know if someone's not get end of life care, you know, not for resuscitation, those sort of things. I think you have to guide people. You just can't let them flounder around trying to make decisions there, and they can accept your decision or not. obviously, if a doctor has concerns about competence or legal implications, then they can get another opinion. And if patients are unhappy about my opinion, and I think maybe they shouldn't dialyse, but they want to, I'm very happy for someone else to look after them. But generally, I'm happy to look after them as well. I just changed the way I'm doing it. So getting second opinions can be quite good. So that's the legal issues. I've never had to do really much with that. Patients generally, particularly rural patients, are pretty good. I did have one patient one time who's, it's quite a funny story in an unfunny way, but this lady was like this guy, you know, she was very frail, and the son wanted her to do dialysis, and she lived out of town, so peritoneal dialysis was the only option. And he was very aggressive about this. And one time I said to my resident, come on, I'll show you how to deal with an angry patient. And 5 minutes later, when we were just about to throw punches at each other, I left saying, we should leave now, I should leave. I'll come back and talk to you later when I'm not so angry. And I remember walking out of the room saying, that's not the way to deal with an aggressive patient. But ultimately she went on to dialysis, on the peritoneal dialysis, had a really miserable time for 3 or 4 months, and then withdrew and died. And he actually came to me later and said, yeah, you're sort of right. It was all pretty amicable in the end. So how would you help Jim's family understand Jim's decision for non-dialysis care? I think that's pretty obvious. It's his decision. He's made a what I regard as a very reasonable decision. And often people want to hear that. So I get them and I say, well, he's made the decision based on the information. And I think that's a really good decision because of this and that. And that's really supporting for the patient. They then get the support that they think they're making a good decision. And the family then can back off in that they don't feel they're letting someone down by not fighting for them. And I think that's quite a useful thing to do. The care recommendations for dialysis is an expectation of the survival with quality of life acceptable to the patient. That's not acceptable to me, that's acceptable to the patient. I had another fellow who was on peritoneal dialysis up at Bingra, I think, or maybe Bingra, I think it was, who had no legs. He has diabetes, he lost both his legs. He was losing fingers. I reckon he only had 2-3 fingers. I don't know how he did his PD. And I said, you know, I won't give his name, Bob, do you think it's time to stop? And he said, after a minute, he looked at me a little bit funny, and he sort of looked at me and said, but Doc, if I stop, I'll die. You know, his quality of life for him was fine. So survival, if you look at survival in elderly patients, and I think this is the group we're talking about, the 1 year survival is 77% to 59-45%. So it's not that great. And the older and the frailer patients, it's much worse than that. It's difficult to actually work it out for an individual. You can't actually say, I think you're not going to live, because I'm often wrong. I say, I think you might live 6 months, and they go on dialysis and they live 2 years. And every day is precious, so that's fine for people. But I estimate 1 to 2 years for these elderly people. And if you've got a lot of comorbidity, it's worse. And if you don't have any comorbidity, it's better. And there are some studies looking at this. You know, if you've got a lot of comorbidity, renal replacement therapy will give you more time than conservative care. And if you've got a high comorbidity, it's the other way around. The renal replacement therapy can actually kill you faster than conservative care. And again, I remember looking after a patient for 5 to 10 years up north whose EGFR was 5, and it was 5 for a long time, and yet she did really well just living in the nursing home. And she had a number of years without dialysis, good quality life, and then she got septicemia and died last year. But if I put her on renal replacement therapy, I'm sure she would have had peritonitis and other problems and not lasted that long. So dialysis is not necessarily gives you more survival, and it's hard. But the factors that are important are age, the older you are, the worse you do, the comorbidities, frailty. I reckon that frailty, you look at someone and you think, oh yeah, it's pretty frail. You're not going to do well. And the social determinant's important as well. Someone who's got no support, no money, no transport, they're not going to do as well. And although that shouldn't influence your decisions, it sort of does, because that sort of person relocating, those sort of things may not be a great option for them to come to terms with away from their social group. So, coming back to Jim, after a series of conferences, the best pathway is a non-dialysis pathway, and what to expect now. So Jim, you see a month or so later, and he's complaining of some pain in his feet. He's got diabetic neuropathy. He's got itch, which is very common in renal disease. He's got restless legs. He's a bit nauseated, a bit breathless. He's having trouble sleeping. And they're pretty common uremic symptoms. And the family think that if Jim went on dialysis, he wouldn't get those symptoms. True or false? Well, obviously, they wouldn't ask that sort of question if it was true, so it's going to be false. Any good medical student would get that one. So if you actually look at the symptom burden of people on dialysis and non-dialysis, then they are different. The dialysis does help with some things, but it doesn't take it away. So nearly everyone on dialysis is going to have Prieritis. They're not going to sleep well. They get this inversion of sleep. They're going to have some restless legs, a lot of depression, anxiety, less nausea, but it doesn't go away. And often, depending on the circumstances, pain, because they're elderly and you hurt when you get older. Various things with neuropathy, etc. So just because you go on dialysis doesn't mean all those symptoms would get better, and that's the bottom line of this slide. So assessing symptoms is really useful. There's this POS renal score, and I'll just show you that in a second. I started to do this, and I still do it, but I sort of regret it, because you actually ask what symptoms people have got, and then they've got them all, and then you've got to try and work it out. It takes you another half an hour with the assessment, and it's not going to be that successful often. So this is the POS score. You can see the things that are on it. This is appetite, constipation, but difficulty sleeping, itching, restless legs. These are all the things that people get, and you can score them. But it is quite useful when people bring this in, and you can actually sort of makes you appreciate that these people have a lot of symptoms. And I worked with my first mentor as a renal physician, said if a renal patient complains of something, don't ignore it, because it's real. And it's sort of true, because they get a lot of stuff. So you see Jim 6 monthly, his GFR decreases to 10, which is about where often people need dialysis. He's got proteinuria. I wouldn't be checking it by that stage, but because it's not going to change anything. But he's still got proteinuria, which is not surprising. And he's actually moved from red to redder, so he's still sick. So what would be the recommended steps for managing pain in the conservative pathway? Honestly, I have no idea. That's where I have to answer, because it's difficult. Refer to a pain clinic, yeah, as if we can do that. Develop pain management plan, possibly. I think that's useful, and giving people realistic goals. That our goal is not to get you pain free, it's just to have you functional, because I think that's a really important goal that people need to appreciate. And obviously determining cause and severity is going to be important. So there's lots of etiologies for pain in dialysis people, from musculoskeletal, neuropathic pain, ischemic pain. They've got all of those things. So it is complex. In terms of management for pain, you as GPs would do more of this than I would. Obviously, we avoid nonsteroidals, but if they're on dialysis and they've got back pain and joint pain, I would use nonsteroidals. If they're on a conservative pathway and they've got terrible pain, and they're not too worried if they live another 3 months, or if they die now, you could still use it. Wouldn't stop me necessarily, depending on what their objectives are. Paracetamol, yep, I guess it's useful. Tramadol, I must say I don't use a lot of tramadol, but I think it's maybe have a role, but I always find people go not so well on that. I think, like we're all using, it's easy to put someone on opioids and then leave the disaster for someone else to tidy up. But they can be useful. I think if you're using them, fentanyl is easier to use. The other morphine type drugs do accumulate, which is not necessarily a problem. You know, I don't mind a drug that accumulates because I can just give it less often. So I certainly use morphine in the end of life situations. Oxycodone, they accumulate, so you just got to be careful of that and use it less often. Hydromorphin is a drug that now is the gold standard. I think that's what people are being trained to use. I haven't used a lot of that, but you just have to remember that it's possibly accumulates. There's a bit of controversy about that. So I think any of the morphine type drugs, you just have to go slow and review and just be aware that they can accumulate. And they can be useful. And obviously, if someone's got 3 months to live, starting them on this sort of stuff may not be such a problem. Other things, common issues, there's lots of these things. You know, hyperkalemia, yes, it's an issue, but if someone's dying, it's not such an issue. Anemia, people are short of breath, exertional shortness of breath, we can fix with EPO. Acidosis is important to correct because if you're acidotic, it makes you nauseated, so correcting that with bicarb is useful. Lots of things that obviously one can look at, but just going to concentrate a bit on restless legs and Prieritis. Anemia, I think we're probably pretty familiar with that. Correct the iron, give EPO, and that can be quite useful. Cognitive decline, I think, is common, and certainly if you put people on hemodialysis, they get this sort of shocked brain when they go on the treatment, and you can see white matter change. So we do expect a bit of that in chronic kidney disease, and I'm sure general practitioners are more aware of doing many handfuls and keeping an eye on that than perhaps I am. Falls are a constant risk, but it's hard to prevent. Delirium, more likely to get delirious if they're in hospital and things because of the uremia. So it's a thing. There's depression is really common. I reckon half my patients on dialysis are depressed. This says a third, but I suspect it's a bit more than that. So it is common, and I think it's more common than just because of the circumstances. I think it's something to do with uremia. And so screening for depression, I think, can be very useful, and just being aware of that and treating that. Obviously, that can be helpful with pain as well, depending on the antidepressants used. Symptoms of depression, symptoms of kidney failure can be similar. So sometimes it's hard to untangle, but I think most GPs would be, aware of depression. That patient who comes in, it makes you feel depressed. That sort of transference of mood, those sort of things are pretty important. If you know your patients, you know if they're not enjoying life. So people can obviously have disability from chronic renal impairment, not being disabled, but if someone's depressed, they can become disabled by it, which is different. Management, I won't go into this in too much detail because I'm sure people in the audience know more about treating depression than I do, but it's certainly worth being aware of and screening for and being aware of, because it actually can make a difference to people's quality of life. And if that's limited and every day is precious, you don't want to be miserable. Prieritis is another thing that's common, as I mentioned. 70% of people will have it. You can improve it with dialysis. If someone has a transplant, you go around the next day and say, "How are you feeling?" They say, "I don't itch." And that's really important. So that's something in the plasma makes people itch. So it's not necessarily a structural thing. It's something in the plasma. People that get better dialysis itch less. May have something to do with phosphate, but I don't think it's such a player as we think. Restless legs is really common. So obviously iron treatment. People with chronic kidney disease don't absorb iron because the hepcidin increases, and that stops the iron transporters in the gut. So treating with intravenous iron can be very helpful for that, and other things. And gabapentin can be useful for that and itch. And gabapentin seems to be great for everything. It can be helpful for neuropathic pain. It can be helpful for restless legs. And it is a useful thing. Just remember that it is renally excreted, the same as pregabalin. So you just need to go slow. So if people EGFR is down around 20, I'll start with gabapentin every second, 100 milligrams every second day. Warn them if they start feeling funny in the head to let us know and we can down track. So I must say in palliative care medicine, gabapentin is like shoot for veterinary surgeons. It seems to be good for everything, so it's worth a try, but it doesn't always work. Nausea will become a problem later on, but not till the GFR is down around about the 10. So Maxilon, metoclopramide, haloperidol, ondansetron probably avoid because of the constipation and things. It is common, but very late. They say don't use cyclozane. I haven't used a lot of that, but if it causes cardiac problems and people die suddenly, maybe that's not such an issue. So it wouldn't stop me using it in the right context. Lorazepam can be helpful for sleep. It is renally excreted, but that's not a bad thing since you just use less of it. So just go slow. Hydromorphin, again, for relaxation can be useful if people are distressed. Glycopyrrolate later on. Dyspnea, often when people get dyspnea and getting fluid overload, basically that's coming to the end of life. And in that situation, I try and bring my patients in and put them on a morphine midazolam infusion. That's the best way to deal with this. You're not going to control it much else with much approach. But it's often an end of life decision. And getting people asleep is the way to go. Dyspnea, you can do all of these things. Lorazepam can be useful. I think that's quite useful. Low dose hydromorphin, those sort of things can be useful. It is actually, I think, as I mentioned before, worth projecting kidney failure and the rate of decline and giving people a prognosis. You're going to be end-stage kidney disease, EGFR. You're losing 10 mils a year. 20 mils GFR now, that's in 1 year's time. You'll be sort of down to the 10 mil. This gives people time to organise themselves. Advanced care planning, end-of-life planning, all of these things are important. And advanced care, end-of-life to me are the same sort of things, but I think people should be given the opportunity to do that and say what they want. And we can explain what we can give in that sort of those terms. So I think, and again, everyone in the audience probably would try and encourage people to have an advanced care plan. You don't want these people being resuscitated by the ambulance or whatever. It's much better to have it sorted out. I tell people my advanced care planning is if I can't look after myself and I can't clean my own bum, then I don't want all this stuff done. And it's a good opening gambit for me to talk about advanced care planning because they know I tell them I've done one. I don't know, there's a lot more to be said about that, but obviously to do an advanced care plan, one needs to know the prognosis, obviously have a decision maker. A lot of people say to me, just you do what you think is necessary at the time, exploring expectations. And again, whether they would want dialysis or not at the end of life, but hopefully I've tried and sort that out before so that we have a pathway decided before. So that's not done at the last minute. Dying with dignity, patients often have a little bit of different what they want compared to healthcare professionals and families, but I think we're all on the same page there, and we want people to have a good death. Terminal care, it's about comfort, and so often, you know, people are okay, and then they get to a certain point and they get sick, and I think, as I said, I'm very, very liberal with morphine midazolam infusions at that time, and make sure, because once they get like this, it's sort of they stop drinking, they're nauseated, the kidney function goes off, and it's a very rapid decline, and trying to eke a few more days is probably not good for them. Delirium can be common, and again, if people are delirious, haloperidol, midazolam. Midazolam is wonderful for this as an infusion or subcutaneously. The delirium at end stage disease won't be reversible. But tell the family that this is not going to get better. I think that's important. Just let it be them that this is the end. So key points, I think treatment decisions is ongoing. You've got to respect the informed decisions of patients or the uninformed decisions that might be. There are some tools in the decision-making process. I think we've just got to be honest and tell people what the outcomes are. I think the take-home message to me of this is that conservative care pathway is a good option for a lot of people, and dialysis pathway is a good option for some people, and they just need to be considered individually. And obviously, general practitioners will play an important role in symptom management. There's always get help from the palliative care specialists and local nephrologists for that. And communication is really important. So I'll stop talking and take any questions that Michelle might have.
Thank you very much, Steve. Look, that was a really interesting presentation, and just really interesting, I think, to hear your discussion of communication with patients and how you discuss these treatment options with them. I love the fact that you can talk anyone in or out of dialysis. That's useful to know. But I think that, yeah, the fact that you tell the patients that all those options are legitimate, including continuing to, be undecided about that care. I think that's a really helpful approach. And I agree with you when you say people want an opinion. I don't think that's paternalistic. Like, I think if we give them all the options, but then say, all right, this is what I would do for my mother or my father, I think that's still, I wouldn't call that paternalistic. I would call that a good way of conveying the complex information to a patient. And I also really love when you said that you tell the patient, I think that's a really good decision for you, regardless of which option they've chosen. And interesting, your observation that helps the family in terms of them feeling okay about the decision the patient's made. So yeah, so thank you for those interesting observations.
Yeah, I think the family, as everyone knows, there'll be always a family member that comes out of the woodwork that's never been involved in anything, and suddenly they want everything done, and that happens invariably. But I think if it's well planned in advance, that can get around that. And but I think it allows the family not to feel guilty that they're making a bad decision when they could have done something and they didn't make that decision. And people do feel that guilt unless that's explored with them, I think. So you've got to actually let the family express what they want. So I don't want you to die, Dad. I can't stand the thought of you being dead, but given all of this, and that's your decision, we'll go along with that sort of thing. It's a just different approach.
Yeah, no, it was interesting to hear that dynamic. We've had a couple of comments along similar lines that said, make sure you include the patient's wife and children in that case discussion, and also most people will respect the guidance by their GP or their specialist. So I think people are sort of in agreement that we do hold a lot of sway over what our patients have said. There's one question about the SGLT2 inhibitors. Can we as GPs initiate SGLT2 inhibitors for kidney preservation, and what is the threshold for starting them?
So the answer is yes, but not necessarily with the PBS. So if they're TGA approved now, so that's you know, so it's a legitimate thing to do. So I think anyone with chronic kidney disease and proteinuria, whether it's GN, so in IgA disease, SGLT2 inhibitors have been shown to actually dramatically improve survival in IgA disease. So in fact, I did a clinic up at Inverell 2 days ago, and I started a couple of people on SGLT2 inhibitors who got GN, not diabetes, but it's a matter of who pays at the moment. So you can start them.
Yep.
Obviously, if you can tweak the PBS somehow to get it on that, that's good. If they've got diabetes, it's fantastic, but getting them when they don't is a bit of a problem. But I think they will be approved. I think they'll end up on the PBS for chronic kidney disease with proteinuria. And clearly they have this massive benefit for heart disease as well. So they're going to be approved for not just for diabetes, I suspect, and they'll come on the PBS for that soon.
Yeah. All right, thank you for that.
Sorry. They're also good for that patient with hyponatremia, who you can't get the sodium up because they're water retaining. So, but they're not approved for that either, but they work.
Right. Okay. Look, just a reminder to anyone, if you've got a question, can you please just put it in the question box, and we'll ask Steve to answer it. Look, the other thing I found really interesting was just your comment about age-appropriate EGFR, because I think that's something that GPs often struggle with when you've got your older patient whose EGFR is still in that 3A category, so it's okay, like it's considered CKD, but it's stable, it's not going down. And I think often we sort of worry, are we doing the right thing by just hanging on to our patients and, just monitoring them, and obviously avoiding nephrotoxic drugs. But yeah, interesting to hear your comments that that's okay to just keep doing that and not send them to you.
I must say, I do get a number of, sorry, Michelle, I'll just take this or else I'll have the security around. Hello, it's Steve, mate. Okay. I'm in the room, so I'll be leaving in about half an hour. So, okay, sorry, my security. Now I've lost the thread. What were we talking about? Sorry.
Just about the elderly patients who have that mild.
Yeah,
CKD.
so often, so a lot of GPs will actually send a referral to me saying, either see this 80-year-old with this, there's no proteinuria, their blood pressure is well controlled, the kidney function hasn't changed really in a number of years, and I'll write back on the referral, look, I could see them, but I don't think it's going to change any management. So sometimes the GPs will actually ask in the referral, do you think you should see them? And I'll write back and say no, unless things are changing. And I think that's that gives you the reassurance that you're doing the right thing. And also, if there's any sort of kickback from family or whatever later on, that you've actually sought an opinion, which I think is a very legitimate thing to do. Because so sometimes you get the impression that people are just doing it not because they really think it's going to make any difference, but they're sort of protecting themselves a little bit. And sometimes you can do that. I can do that.
I think that's, I think that's true.
Reply on a referral. Yeah.
Yeah, well, that's helpful to have that. Yeah, just have that piece of advice on the letter, on the letter back. We've got a question. Roughly, what EGFR would someone expect to see uremic frost at? EGFR of less than 15?
Yeah, it's a really interesting question. I've possibly seen it once. So if you live up in Armidale and someone comes in with frost all over them, they've probably got frost on them, and it's not going to be uremic frost. It's pretty rare. It's pretty rare. It's going to be less than 10. People really don't get many symptoms until they're less than 15. So there's not much happening. They're a bit tired and lethargic. They don't retain water until the EGFR is less than 15, and then it all happens, and it happens quickly. And so it's actually very rare to get uremic frost. you'll get nausea, you'll get vomiting, you get weight loss. They're the things that twig me to start thinking, okay, this person's now need to be dialysis. And in fact, I don't put people on dialysis because of a GFR. I do it on the eyeball test. I bring them in and I look at them and they just look crook, and I think, okay, it's time to start dialysis. And that could be a GFR of 8, it could be an eGFR of 10, 12. Once it's less than 15, it's all on, and it's really how they're feeling. You see, I've got a fellow, I saw on Thursday, there's a young guy, he's working in the meat up at Inverell, and he's got an eGFR of 8, and he looks like Arnie Schwarzenegger, and he's working full time. So does he need to start dialysis? Well, probably not. It'll just actually muck up his job and he won't have income. So we're just watching very carefully, but he's close, but he doesn't actually need to start dialysis at the moment. Just because his eGFR is 8.
Yeah, that's really interesting that someone could have an eGFR of 8 and still be functioning relatively well and look okay.
And particularly elderly people do handle those GFR. I think they handle it much better than younger people. So an 80-year-old with an eGFR of 8 is going to be all right. They're probably functioning all right because they don't, when you get to 80, you're not doing that much. So you're not sort of missing out on, you don't get short of breath and things because you don't actually run marathons. So they handle the low GFR much better than a younger person. And the conservative pathway is not, it's quite a reasonable way of approaching it.
Okay. We've got another question. How does one investigate for possible amyloidosis as an underlying cause of CKD? Yeah,
it's a good question because it's a bit tricky. So I used to teach that everyone with amyloidosis will have nephrotic syndrome, but that's wrong. So I've seen amyloidosis without proteinuria, because it depends where it is. So if it's in the glomerulus, in the basement membrane, you'll have proteinuria. If it's in the blood vessels in the kidney, you won't necessarily have that. So what you will see is big kidneys, relatively big kidneys. So someone going into renal, this is not acute renal failure, but chronic renal failure with kidneys of 10, 11 centimetres. So on the ultrasound, they look pretty good. They look like normal looking kidneys, and yet they're not working. Can be something in the urine like protein. Any old people, I always screen for paraprotein. So I do an EPG and an IEPG and serum free light chains. Often you'll pick it up on that because it'll be a lambda light chain that causes amyloidosis. So it'll be IgG lambda or IgM lambda. It's always lambda for amyloid, if it's the usual amyloid, secondary amyloids. There's lots of causes of amyloid. But, so sometimes, it requires a kidney biopsy. So there's a girl in Armidale that I look after who's type 1 diabetic, and she was really stable, and then she suddenly developed proteinuria, which diabetes doesn't do that. It takes years for that. It doesn't go from microalbuminuria to macroalbuminuria in 12 months. So I did a biopsy and she had amyloid. Now, so there's not many things that cause good-sized kidneys with renal impairment. Diabetes is number 1, number 2, number 3, number 4, number 5. But if they're not diabetic and they've got big kidneys and renal impairment, you've got to think about infiltrative disease, and that's amyloid, sarcoid, lymphoma, those sort of things. But they're the one. That's the clue, I think. Big kidneys not working very well. I'd always be suspicious about amyloid, and a kidney biopsy is going to get it for you. You can biopsy skip. I found that particularly unhelpful.
Okay.
So, kidney impairment, good-sized kidneys, think amyloid.
Yeah. Look, I think we've come to the end of our questions, so we might call that a day. So look, thank you very much. Really interesting presentation, and I think really helpful just thinking through those, what to do about those patients when they get to that point of needing to consider renal replacement therapy. So thank you very much, Steve. Jenny, I'll hand over to you.
Thanks very much, Michelle, and thanks, Dr. May, very much. Our next CKD webinar is on the 4th of November, and our presenter is Dr. Malcolm Green. When the webinar, when I click end, the evaluation will pop up, and we would love to get your feedback. So if you could please fill it in, that would be great. This webinar is not recorded with RACGP, but you can self-record your points and you will get a certificate tomorrow. Thanks everybody for attending, and we'll see you next time.
Yeah.
Jenny's gone.
Thanks, Michelle.
Well, thanks, Steve. Yeah, look, really enjoyed your presentation. It was really interesting. So thank you for that.
Okay, how's life up in Armidale?
Not too bad. We sort of, yeah, I think things have been okay here. We've been a bit busy with all the COVID vaccinations, but we had the one family that had COVID about, I think it was 6 weeks ago. But that, it was all just in the one family and didn't spread any further. So, like you, we are hoping we can avoid the pandemic for a bit longer. So,
yeah. So I sort of missed coming up to Armidale. I used to enjoy that, but I'm sort of glad that I don't, because just the travel and all of that. It's been handy.
But you're obviously still travelling to Inverell.
And Moree,
Yeah.
I'm getting Dr. Green up to speed, so.
Oh yeah, no, it's good. It's good to have him around.
Malcolm's great. Yeah. Okay, Michelle. Well, thanks very much.
All right. Well, have a good evening.
Yep. You too. See you later.
Nice to talk to you.
Yep.
See you later.